So what I would like to do is give an overview of what's happened in Europe and how that interacts with what's happened in the States over the last few years and what we anticipate will happen over the next year or so, and also try and answer a few specific questions that people have asked. These are the questions, people don't need to read these now, but these are specific questions that people have asked. So I will have tried to incorporate the answers to these in my talk, but if we haven't covered anything, then we can go back to it at the end. So immunotherapy offers the potential to give highly specific treatments. So most chemotherapy, radiotherapy targets cells that are dividing and growing, which doesn't distinguish it from normal cells in the body, such as the bone marrow. The beauty and the attraction of immunotherapy is that you're specifically targeting proteins or molecules on the surface of cancer cells, which are different from those of normal cells of the body. So you can potentially specifically kill that cancer cell and leave the normal cells of the body alone. As over 100 years ago, this gentleman here postulated that there were antibodies, he didn't call them antibodies at the time, but proteins in the blood which could potentially act as magic bullets, coating and targeting cancer cells and eliminating them from the body. It took us almost 100 years before we really started to reap the benefits of that therapeutically as medical treatments. In the 1970s, these two gentlemen, Kohler and Milstein, invented the technology to produce and develop antibodies in culture in the lab so that we could make unlimited quantities of pure antibodies. The monoclonal means it's pure, against really any specific protein or antigen that was desired. And as you can see from here, this is the kind of basic structure of the antibody. So they're Y-shaped structures, and at the top you have the bits that are very specific for the protein that you want, so the antigen binding site. So that really is kind of like a lock and key mechanism. So if you make an antibody for something like GD2, it will only recognize GD2 and not all the other proteins in the body. And then at the bottom end, you have a constant region which interacts with the immune system of the body. And so what we think happens when we use antibodies to target cancer is that your antibody that you've produced binds to and coats your cancer cell by binding to the specific protein that's on your cancer and not on normal tissues. And then the cells of the immune system, so here natural killer cells, will come in and bind to the other end of the antibody and will release chemicals which kill the cancer cell. And GD2 has been the antibody which has been most explored as a target for antibody therapies in neuroblastoma. And it's a good target because GD2 is on almost all neuroblastoma. So most tumour antigens aren't on every single cancer from a particular type of cancer. So we're lucky in terms of neuroblastoma that virtually all neuroblastoma has GD2 on its surface, so we don't need to test children to see whether the antibody is going to be suitable. We think it will bind to all neuroblastoma. And there's relatively little GD2 on other cells of the body. So some proteins that are on tumours may be more on tumours, but there may be some on other tissues. But GD2 is relatively little on other tissues, except for nerve tissue. And you'll all be aware of the fact the side effect of anti-GD2 causing pain, and that's because it binds to nerve tissues and stimulates the nerve causing pain. So there's been three main antibodies that have been used clinically in children with neuroblastoma, which you may well have heard about. The first is dinutuximab, which is produced by United Therapeutics, which has been the antibody that has been most widely used in the United States and was used in the LSU COG study. The very closely related dinutuximab beta, which is produced by Aperam Biologics, which has been most widely used in Europe. And then 3F8, which recognises the GD2, but is a completely different antibody, but it binds to the same molecule. So the first two, dinutuximab and dinutuximab beta, came from the same original identical antibody, but had been grown in different cells in the lab. So they both recognise GD2 in an identical way and bind in the same way, but they may have slightly different interactions with the immune system, so the effects may be slightly different. So in terms of how they're viewed by the regulatory authorities and that control licensing of drugs, they're viewed as completely different products, but they bind to the same molecule but may have slightly different effects. So the kind of pivotal study in terms of anti-GD2 therapy the results were released in 2009 by LSU and the Children's Oncology Group, and I'm sure most of you have heard of this study. And in this study, they gave the anti-GD2 antibodies, the dinutuximab, with interleukin-2 and GM-CSF. And the aim of giving those two molecules, as well as the antibody, was to try and increase the amount of natural killer cells in the child, so that there was more cells there to kill the tumour cell once it was coated with antibody. And that was based on results from the lab suggesting that the more natural killer cells you have, the better the killing of the tumour cell is. And it's intuitive that it may be effective. And in that study, and I'm sure you've seen this graph before, the results that they reported was that at 2 years, the number of children who relapsed was significantly less in those children who had had this antibody therapy, so the dinutuximab plus IL-2 plus GM-CSF, as compared just to standard high-risk neuroblastoma therapy. And that really changed practice throughout the States and throughout Europe, and within months of that we introduced antibody for all children with high-risk neuroblastoma in the UK and Europe. We learnt a number of lessons from that study. Firstly was that the antibody, although it's very specific and binds to the GD2, it does have significant side effects and toxicity. The most obvious one is the pain, and in the American study, most children needed morphine infusions while they were having it. More troublesome can be that you can get this thing called vascular leak, where the blood vessels become leaky and the child can become puffy and edematous and can really become quite sick and need to go to intensive care. In the study, because all children got the antibody and IL-2 and GM-CSF, it wasn't clear how important the IL-2 and the GM-CSF were, and it may have been all the benefit was the antibody, but it wasn't clear whether the actual IL-2 and GM-CSF added anything to that. What was clear was that those agents, particularly the IL-2, added to the side effects and toxicity. So in the American study, alternate cycles of antibody were given either with IL-2 or GM-CSF, and it was very clear that the cycles that had IL-2, patients were much sicker and the chances of going to intensive care and having real problems were much greater. And finally, the other important lesson was that although this was really exciting and a massive step forward in terms of neuroblastoma treatment, it still left a large proportion of children with ultimately with relapsing disease. And this is the updated results from the COG study, from LSU study, which are publicly available. And I'm afraid that the lines aren't very clear, but if you can see the top line, the black line is the original antibody line, and the red line is the original standard treatment arm. And you can see how big the gap is between the black and the red. And so at 2 years, there was a 20% difference between those two lines. That data has now been updated in 2014, and this green line is the updated antibody arm, and the blue line is the updated standard arm. And you can see how that gap has closed with time. So there is still a difference, but when the statisticians look at those numbers, because there are far fewer children who have gone all the way out to that time point, those differences become lose their significance. That doesn't mean it doesn't work, but it means there's no proof that it does work in the long term. And what you ideally need is much bigger numbers of children in at both of those arms to prove that that difference is real and not just by chance that those lines are different. Ideally, what you would do is do a repeat study with much bigger numbers, but obviously that's very difficult now because having a randomized study where you gave some children no antibody and some children the antibody would now be very difficult. So since 2009, 2010, when those results were released, the work in Europe and with SIOPEN has been to try and improve not only the efficacy and how well the antibody works, but also how well it's tolerated and is able to be delivered to children. And there's been two main studies in Europe which have addressed that. The first has been the high-risk study, and then the second, the long-term infusion study. Until 2010, this was the pattern of treatment for the high-risk study. So children got induction chemotherapy, had their operation to remove the tumour, had high-dose chemotherapy with busulfan melphalan, radiotherapy, and then had retinoic acid. And that high-risk study, as Kate said, almost virtually all children with high-risk neuroblastoma have been treated on that. In 2010, randomisation was added to that based on the results in the American study, whereby children were either given antibody alone or antibody with the IL-2. And that was on the basis that we knew that the IL-2 was very toxic. More children went to intensive care with it. And actually, if we didn't know it was really contributing anything, then that was the most important thing to work out whether it was of benefit or whether it was just doing harm to children. In order to go into that randomisation, children had to have had a good response to treatment up to this point, and that's on the basis that we think that the immunotherapy is most effective if children have achieved a very good partial response or complete response by the time they get to that point. If they've still got lumps of disease, then it's probably less effective. And in the ALICE-U study, children entering the randomisation at the beginning had all achieved a very good response by that point. So the early results of that randomisation are here, and the red line is the antibody alone, and the blue line is the antibody plus IL-2. And what you can see is that the lines are very close in terms of the number of children that have relapsed, suggesting that there is no significant difference in relapse rate. And the number of children in this was about 400 in total, which is roughly twice the number that were in the American study. So this is with decent numbers of patients. Now, one of the other observations from this was that the amount of side effects that children experienced was significantly greater in those that had the antibody. So this is a funny type of kind of graph to show the side effects. Down the middle is if there was the same amount of side effects with the two different arms, so antibody alone or antibody plus IL-2. The yellow bars show whether there was more side effects with the IL-2 or without, and you can see that all the yellow bars are over to the right here, confirming what we expected, that the side effects are much greater when you give the IL-2, and those are temperature, low blood pressure, needing to go to intensive care. The importance of that is not just, it's obviously distressing for the child to have those side effects, but also it resulted in far fewer children who were having the interleukin-2, the IL-2, fully completing all the antibody treatment. So if you look here at children who completed all the therapy and all the cycles, for the antibody alone, 84% of children completed all the treatment, whereas only 51% of children who had the IL-2 completed it all, and 20% of children actually had to stop cycles completely. So that's important because if you're not delivering the therapy, then it doesn't have a chance to work. So what was the kind of analysis we've done on the basis of that was to try and pull out those children who did complete all their treatment. So if you just pick out those children who got all their treatment, there did appear to be a difference between the two groups. So this is the IL-2 group at the top and the antibody at the bottom. So you can see there's a difference between the lines, showing that fewer children appeared to relapse when they just got the antibody. But this was in a very small number of children who'd been picked out of the group, and statistically that's not something that you're allowed to do. You can't just select out a group and say, oh, well, that obviously works. But it does suggest that maybe if we could deliver the treatment in a more tolerable way that children could tolerate without having to stop the antibody, then we can't dismiss the fact that IL-2 does something at all. So it doesn't prove that IL-2 works, but it gives us reason not to give up on it completely. So in parallel to that, the long-term infusion study has been looking at trying to reduce the side effects of the antibody delivery by giving it as a much slower infusion. So one of the things that we noticed when we started giving the antibody was that if children had side effects, whether it was pain or allergic reactions or low blood pressure, then actually the best way of treating those was to slow down the rate that the antibody was going. And the thing that has been piloted and now has become widespread and used routinely, initially started in Germany, but now throughout the UK, is these infuser pumps whereby children are attached to these pumps with a bag full of the antibody, which is slowly released over 5 days without any batteries or power supply. It's just a completely kind of it's got an elastic in the balloon that the antibody is in, which reduces it at a constant rate, which gives the potential for the child being at home if they're well enough. So this study opened in the UK a few years ago and really has shown that fewer children given the antibody like this need intravenous morphine, and many can be discharged home on oral morphine, which is obviously a big advantage. But also that potentially the levels of antibody that you achieve in the blood are much better if you have the antibody going slowly for a longer time, because it stays, it's going for longer and you get high levels for longer, which is good in terms of killing the tumour cells. So what is now happening within the long-term infusion studies, we're looking again at the question about IL-2. Now that we've got this safer way of delivering it that's better for children, can we see whether the IL-2 can add anything to treatment? So children now are all getting the 10-day infusions. They get the ball attached at the beginning and then changed after 5 days and go home if they're well, and then half of them will get antibody and half of them will just get all of them will get antibody and half will get IL-2 and half will just get the antibody. In terms of that study is open to children who aren't eligible to the high-risk study because their response has been too slow or because they've got relapse disease. So in terms of the high-risk study, which children go on to the beginning of treatment and stay on if they respond well, what we have done is to now incorporate the long-term infusion model of giving it with the balls if possible, and again look at giving the IL-2 in this context. In this study, we're looking at the IL-2 at a slightly lower dose, so 3 international units rather than 6, because, again, that is likely to reduce the toxicity and side effects of the IL-2 and may be sufficient to activate the NK cells without so much side effects. So on the current long-term infusion study, the children get the bigger dose of IL-2, and in the high-risk study, they'll get the slightly smaller dose. So just to summarise the IL-2 situation, in the COG study, the IL-2 was given as an intravenous infusion, so continuous infusion like the antibody, initially at 3 international units a day, and then 4.5 for the second week. In Europe in 2010, we have given it as an injection, a subcut injection, because that's more convenient for children. And also there was previous work done within Europe that showed that this is well tolerated by children, can usually be given as an outpatient, and that dose should be effective at increasing the NK cells. That randomization on the initial R2 was stopped in 2013. In the LTI study, we're still giving that same dose of interleukin-2 to look at whether that dose is effective with the slow infusion. But the new randomization, which is just opening in the high-risk study, so R4, will look at a lower dose to see whether that dose is better tolerated and may be effective at increasing NK cells and improving the antibody. So it is confusing, but there is some logic in the changes that have happened within Europe and the fact that they seem slightly contradictory. So I know lots of people have asked how the results within the US compare with those in Europe. It's very difficult because there's not a head-to-head comparison. What you really need to see whether one treatment is better or the same as another is to treat the same population of patients and do a randomized study. But what has been done within Europe is try and compare the 2-year event-free survival, so the number of children who are free of relapse at 2 years in the two studies. And these numbers at the bottom are probably the best to look at. And if you look at the numbers in the European study at the top and then the LSU study at the bottom, they are very similar. So as best as we can compare, the 2-year outcome between the two different types of therapy are very similar. In America, they are continuing with the way the antibody was delivered in the COGS study, and that is their standard. But in Europe, we feel that the results that have been achieved here are comparable, and we're looking to improve further by looking at the role of IL-2, but we're quite comfortable that the results that have been achieved are comparable. Somebody asked a question about GD2 after haploidentical stem cell transplant, which has been done in Tübingen in Germany. And this is just really to answer that question. And this is straight from a presentation that was done in ASCO, so the big cancer conference in the United States. And these are the latest results from the Peter Lang in Tübingen study, whereby they've taken children with relapsed or refractory neuroblastoma, and the children have undergone high-dose chemotherapy and a stem cell transplant using a parent as a donor, so it's only half match, that's the haplo bit, and then given antibody starting from 2 months afterwards. And what the results of this study showed was that over a third of the children didn't reach the end of the protocol, either due to side effects, one death due to treatment, or progression during treatment. So that's a pretty high number not going through the treatment protocol. 8 of the 34 patients treated maintained a remission that they were already in. 9 of the 34 patients improved their disease status, and some of those achieved a complete remission. And about a tenth of the patients, the disease was unchanged. So those, again, it's hard to compare those data with the long-term infusion study, but actually I don't think they are vastly different. It's a potentially toxic treatment because it's a high-dose therapy, and I think at the moment the results that are coming out are not significantly better than those seen in the long-term infusion study. For patients treated on the long-term infusion study in Europe that have got measurable disease on scans at the start, approximately a third will have an improvement in those scans, some of which are complete remissions during the course of the treatment. So I think it'd be nice to do a direct comparison between the two, but those are the results at present. Within the UK, we are planning a new study to try and improve how anti-GD2 therapy works. And this is going to be called the Zigzag study, and this is Daniel, myself, and John Anderson are proposing this. And what we are proposing to do is to combine the antibody with something called zoledronic acid, which John Anderson has very good lab data to show that using zoledronic acid and a low dose of IL-2 can increase cells called gamma delta T cells, which are not only very good at killing neuroblastoma cells when they're coated with antibody, but may also be good at generating a long-term immune response. And so we're submitting an application for funding to this to Cancer Research UK, and we hope, if that is successful, that we will open in early 2017 as the current long-term infusion study closes. One advantage of this is that it will be open to children who've already received antibody. Because it's using a different mechanism of action, different cells in the body, we think it will be still potentially beneficial to children who've already had antibody. So it will be hopefully open beginning of 2017 at, we anticipate, the same sites as the LTI study is now. So just finally, I want to spend a few minutes talking about a different antibody approach, which has been, you may have seen, more broadly reported in the press, and that's to use antibodies to boost the body's own immune response. So when you give anti-GD2 antibody, you're giving passive immunity, so the antibodies you give last in the body for a few weeks but are then gone. And what would be really nice is if we could use antibodies to generate long-term immunity. just like when you immunise against measles, you've got long-term immunity. And we know that although there are these proteins or antigens on the surface of tumour cells, and the body's immune system can recognise these as foreign, the immune response that the body generates is generally weak and doesn't control tumour. And that's because there's hundreds of different switches and control mechanisms that tightly regulate the immune response in the body so that you make an appropriate immune response to the circumstances. So if you get an RC infection, your body will make a strong immune response because it senses all the danger signals and all the switches are switched on. Cancer is much more subtle. The differences on cells are much tinier than that of bugs and infections. And so it doesn't alert all the danger signals in the body, and generally the immune response is pretty tiny. What has been found over the last 10 or 15 years is that we can actually use antibodies to switch on these molecules in the immune system, to turn all the off switches to on, so that we turn up the volume on the body's own immune response to generate an effective immune response. And so this is targeting the immune system itself, not the actual cancer cell, so that the immune system then recognises the cancer, and it's boosting the body's own immune response to cancer. And the big advantage of this, it has the potential to generate long-term immunity, not just immunity for the length of time that the antibody lasts. And the antibodies that have been used and most reported clinically in adult cancers are ones targeting anti-PD-1 and anti-CTLA-4, which have had a lot of press this year. And this is just an example of the impressive results that this type of antibody is generating in adult cancers. So this is a patient with melanoma given, and this is the 0 line here is if the patient's disease stays exactly the same. All those lines below are tumours that have shrunk, and these are ones that are grown. And you can see with patients with metastatic melanoma, which is very difficult to treat, the majority of patients treated with this type of antibody, the tumour shrinks, many of which it completely goes away. And here's an example of a tumour on somebody's face melting away with treatment. And this is a biopsy taken from the tumour, and these black dots show immune cells, lymphocytes in the tumour, showing that you're triggering the body's own immune response to tumour. And these antibodies are very quickly developing in adult clinical practice, and several have been licensed and approved for treatment in adult cancers. What's encouraging is that a lot of the results are not just in the cancers that we think of as stimulating immune response like melanoma, but they've now been used for lung cancer and bowel cancer, breast cancer, things that we don't generally think of as being recognised strongly by the immune system. And there's now over 60 trials in progress just of this one antibody, anti-PD-1, in adult cancers. So they've attracted a huge amounts of attention and are really changing the face of adult cancer therapy. What's not clear is whether this type of antibody will work in paediatric cancers. This graph shows the number of mutations in the genes in different types of cancers. And at the far end here are cancers with lots of mutations, very mutated cancers, and we've got melanoma and lung cancer because of all the kind of UV light and tobacco smoke causing lots of mutations. And right at this end, with low levels of mutations, we've got the paediatric cancers such as neuroblastoma, I think is on there somewhere. And what this means is that the number of different proteins on the surface of paediatric cancer cells is probably lower than adult cancers. So adult cancers are probably more foreign to the immune system than paediatric cancers because there's more mutations. And the potential for this is that because paediatric cancers are not as well recognised by the immune system as adult cancers, this type of antibody may not be as effective as it is in adult cancers, but we don't yet know. We've done some preclinical work in the lab looking at the effect of these antibodies in neuroblastoma models, and we see regression of neuroblastoma with this type of antibody. So these are the tumour growing, and then it shrinks away and goes into remission with the treatment. And this is with the antibody, the survival, and not without. But we have to remember that the neuroblastoma models that we use in the lab do not necessarily reflect human neuroblastoma in terms of how foreign they are to the immune system, and these are generally much easier to treat than human cancers. We've also looked at the amount of PD ligand 1 on the surface of neuroblastoma and other pediatric cancers, and in the adult cancer trials, this has been shown to be a marker of response to anti-PD-1, and we found high levels of this in a range of pediatric tumours, including neuroblastoma. So this and the work in the mouse models is encouraging, but we really won't know until we've tried these in children as to whether they're going to be as effective as they seem to be in adult cancers, and I think we should be cautious about that. The first paediatric trials of this type of antibody are just on the way. So nivolumab, which is one of the major PD-1 antibodies, is now open in the United States. Pembrolizumab is a different antibody, also recognising PD-1, is open at the Royal Marsden. And this atezolizumab, which binds to a slightly different bit of the PD-1 pathway, is opening in about 8 UK centres early next year. And these will all be phase 1 studies, so the first trials in children to check out the dose and the side effects in children prior to testing in a randomised way. And they will be open to all children with relapsed tumours, not just neuroblastoma. And then if there's encouraging results in particular tumour types, there'll be an expansion group in those children. We are contemplating and proposing a combination study to combine these two approaches, so combining anti-GD2 antibody, which directly targets the tumour, with anti-PD-1, which targets the immune system, together with MIBG therapy, because that may have some beneficial effects on the immune system. As a collaboration between myself and Mark Gaze at UCLH, Holger Loder in Germany, and Paul Sondel at Madison in the US. That trial is in early stages of development, but we hope that may be a very powerful way of combining these types of therapies as a new treatment, but that's at an early stage. So finally, to conclude, I would say that anti-GD2 antibodies improve outcome, but relapse rates are still significant, and we need to improve and optimize this therapy more in order to cure more children. The SIOPEN studies have improved the side effects and the way we deliver antibody. The role of IL-2 is still not clear, but we're addressing that. There may be other ways to improve antibody killing by for example, zollogenic acid, which we hope a study will open in about a year's time. And this new class of antibodies, anti-PD-1 antibodies, are showing very promising results in adults, and the first paediatric studies are in progress.